Pathophysiology of Preeclampsia. Preeclampsia is a dynamic and progressive process. It is essentially a syndrome with multi-organ involvement, with adverse maternal and fetal effects as a consequence of vasospasm, endothelial dysfunction and ischemia. The pathological changes in the organs are thrombosis of capillaries, smaller veins and arterioles with hemorrhage and necrosis. The pathological changes in various organs are: first, uteroplacental bed. Due to vasospasm of uteroplacental vasculature, the mean diameter of myometrial spiral arterioles is reduced, causing increased perinatal mortality and morbidity through intrauterine growth restriction, abruptio placentae, placental infraction and iatrogenic prematurity. There is increased resistance to blood flow in uterine arteries in women with preeclampsia on Doppler velocimetry as compared with normal pregnancies. Second, cardiovascular system. There is severe disturbance in the normal cardiovascular functions in hypertensive disorders during pregnancy, depending upon severity of hypertension, presence of any underlying chronic disease, presence of preeclampsia, and duration of pregnancy and disease. There is contracted plasma volume and hemoconcentration in preeclampsia along with increased systemic vascular resistance, normal or decreased cardiac output and decreased cardiac preload. Besides, there are increased levels of thromboxane A2 and decreased level of prostacyclin and nitric oxide in patients with preeclampsia. The vessels of these women are more responsible to angiotensin II levels. These changes are responsible for endothelial damage, vasoconstriction and increased peripheral resistance. Central venous pressure and pulmonary wedge pressure are reduced in preeclamptic women. Now, blood and coagulation. While most women with preeclampsia and eclampsia have a normal coagulation profile, hematological abnormalities in the form of thrombocytopenia, that is the most common, microangiopathic hemolytic anemia, increased blood viscosity, hemoconcentration and sometimes even disseminated intravascular coagulation may be observed in some women, especially with more severe disease. Third, volume hemostasis. Fluid and electrolyte changes. Most women with severe preeclampsia have edema, which is possibly due to endothelial injury. Fourth, renal changes. The various changes observed in renal glomeruli in preeclampsia are as follows. First, glomerular enlargement. The endothelial cells are swollen, their fenestrations and pedicels are narrowed. Second, hyaline, foam cells and pouting of glomeruli and fat in glomerular cells. Third, deposition of IgM fibrin and thrombi in the glomerular capillaries. Fourth, thickened epithelial tuff with vacuoles. These changes lead to reduced GFR, increase in blood urea and serum creatinine and proteinuria. Fifth, hepatic changes. The hepatic changes of preeclampsia are characteristic. Its surface is smooth with malted appearance due to numerous scattered areas of subcapsular hemorrhage. Sixth, changes in the brain. The changes spare the brainstem area but affect posterior hemisphere. CT scan and MRI may show the following abnormalities. First, cerebral edema and edema in occipital white matter. Second, cerebral hemorrhage and hemorrhage in ventricles, parenchyma and subarachnoid space. Third, fecal hypodense areas due to petechial hemorrhage and local edema. Fourth, normal cortical sulci are lost. Fifth, sudden development of hydrocephalus. Sixth, basal ganglion infarcts. Seventh, cerebral infarcts. Headache, visual symptoms and convulsions occur due to brain involvement in the disease process. Electroencephalogram shows increased irritability of cerebral function, explaining exaggerated reflex on examination. Seventh, visual disturbances and retinal changes. Visual disturbances like blurring of vision are common in severe preeclampsia. Eighth, changes in the respiratory system. Various respiratory changes which can be seen as follows. First, pulmonary edema. Second, scattered alveolar hemorrhages. Third, adult respiratory distress syndrome. Fifth, chemical pneumonitis. Ninth, other causes. There may be subendothelial hemorrhages in heart or focal necrosis or hemorrhage in the myocardium, which can affect the conduction system and may cause cardiac failure. Thank you for listening. Thank you.